Hello and welcome back. Okay, you all heard that squeak out, right?
Yep.
Sorry about that. But it's the weather. It's a little dry. I'm not sick. And not that you would catch it anyway. Daniel might, but I'm not sick. I promise. So we just had a nice break. I hope everyone enjoyed their holiday time. And we come back tonight doing chapters 18 and chapters 19. Before we start, I didn't get many emails over the break, so I'm going to assume that everyone is doing just fine in everything. No one had any major questions that emailed me. I think I had half a dozen emails over the whole break. So that tells me that everyone is doing fine. Is that the case?
Yeah. I think so, yeah.
Is it making sense?
Yes.
More sense since we went over the CPT book?
Mm-hmm. That helps.
Right. And how about doing the exercises in class?
That is nice, I think.
You find that it helps you when you go home to do the assignments?
Yeah. Yeah.
Okay. Then we will continue that. Now, it doesn't seem possible, but we're halfway through the book. There's just 31 chapters, and we're on chapter 18. So we're halfway through the book, and we're about halfway through the course. So we should be done, I think, the first week of March. I don't remember when February vacation is. And that is also if we don't have any snow days. Because if they call a snow day and they don't have school, we don't have class. So let's start with the integumentary system. In your textbook, let's turn to page 526. And have your CPT books open to page 71. Excuse me. And just a reminder, everyone does have the answers on Evolve for the textbook, workbook. So you should be able to find those all online. And if you have any questions afterwards about, you still weren't sure how they got the answer, definitely get in touch with me, okay? All right. So I'm going to spring a little quiz on everybody. But it's just an interactive quiz. So what is it called when one is coded independently each time it's performed? What is it called when something is coded independently each time it is performed?
Post?
Good. Sorry.
Board post?
No, it would be considered a separate procedure. Okay? The cleaning of a wound or an area is called what?
Debridement.
Yes, debridement or debridement. The integumentary system is formatted on the basis of what? It is formatted based on the anatomic system or the anatomic site. So, as we learned, seems like many moons ago, with our CPT book, it is broken up into different categories. And if you look at integumentary, It is by anatomic site. So the first area is going to be the skin. As you move into the chapter, into the CPT book, you'll find that we have skin tags, we have malignant lesions, we have nails, then the repairs, whether they're simple, intermediate, complex. We have tissue transfers and grafts. We have flaps, pressure ulcers, burns, destruction. And within each of these categories, you'll see it moves into the anatomic sites. So we would then have breast in there, mastectomy, and that takes up the integumentary system because if it has skin covering it, it's falls under that system. All right. The removal of a small amount of tissue for diagnostic purposes is called what?
Good. Biopsy?
Yes, biopsy. The integumentary system subsection is divided into how many subheadings? How many subheadings? We have 7. 7 subheadings. All right. What is an autograft? What is an autograft? An autograft is a man-made graft. All right. Are dermatologists the only providers who would report codes in the integumentary system subsection of CPT? Darcy, what do you think?
Sorry, can you repeat that?
Are dermatologists the only providers who would report codes in the integumentary system subsection of the CPT book?
I would say no.
Correct. Correct. Even though dermatologists specialize in the diseases of skin and the accessory organs, you'll find that many practitioners out there know how to take off skin tags or wart removals and stuff like that. What are the major factors that are considered when coding wound repairs? Fran, can you tell me what the 3 factors are?
Yes, hold on. All right. Length, complexity, and site.
Yes, perfect. All right. So that was just a little warm-up, okay? Got your juices flowing? Okay. So I don't stress a lot on the terminology in this course because obviously you've gone through terminology. Excuse me. So with your integumentary system at the top of page 526, this is often used in all specialties of medicine. And it is not just for surgeons or dermatologists. you will find that there are a wide range of physicians who use or do things in the integumentary system. So some of the examples of the specialties and procedures might require codes that we see in the integumentary system. Your family practitioner might use debridement or repair codes. A dermatologist will use excision and destruction codes. And your plastic surgeon may just use skin graft codes. And a surgeon may use your breast procedure codes. You'll find that the subheadings of the integumentary subsection are listed there on page 526 in your textbook. Skin, nails, pilonidal cyst, introduction, repair, destruction, and breast. In repair, you'll see that in this chapter it means closure. Over on page 527, we talk about introduction and removal. This would be code 10030. You'll notice in your CPT book that it has a bullseye next to it. What does that bullseye mean? Does anyone remember?
That's when they put you under conscious sedation, or moderate sedation.
Moderate sedation, yes. Excellent. Okay, so with the introduction and removal, this reports the percutaneous image-guided fluid drainage of a catheter collecting soft tissue. So introduction and removal, think about that. Introduction, what are they doing? They're introducing the image-guided needle or whatever it is they're using through a catheter to collect something, to collect a specimen from the soft tissue, such as an abscess, a seroma, a cyst, a hematoma, or a lymphocele. So that's what is meant by introduction. And then the removal piece is where that little snare that's on the end of what they've introduced through the catheter takes the specimen. That's what's meant by removal. All right. Incision and drainage, right below that. This is an incision and drainage of an abscess, or a carbuncle, or a boil, or a cyst, some kind of infection or hematoma. You'll see down at the bottom right-hand corner on page 527, I joke that that's my favorite picture in the whole book. Because honestly, it's not fun to look at, but you've got to make light of it, right? Because it actually does happen. So
makes you want meatballs, doesn't it?
Oh yes, absolutely. So how would we take care of let's just say an abscess or a boil? We might lance it. What is lancing? Lancing would be cutting of the skin. Aspiration, we might remove it with a needle. If you look at codes 10040 through 10180, you'll find that these are grouped according to the condition for which the procedure is being done, such as acne surgery, abscess, carbuncle, cyst, hematoma, postoperative wound infection are just some of the examples. So how would we determine that an incision and drainage is being done? Or how would we determine an incision and drainage code? What do you think? First of all, they're going to be divided by the condition that they are used to treat. And then secondly, they're going to reflect whether it is simple versus the complicated and multiple site procedure. Does that all make sense to everyone? Okay, so
Yes.
the condition, and then is it simple or is it complicated? Do we have multiples? Okay. All right, excision and debridement. These are codes 11000 through 11047. So 11000 on page 72 in your CPT book. Okay, this is where dead tissue is cut away and washed with saline. So you'll notice in these codes 11000 through 11047 that it lists debridement of, and it tells you. It tells you if it's extensive. It tells you each additional 10%. It tells you if it's subcutaneous tissue or if it's abdominal wall. It tells you if it's removal. It tells you if it includes removal. So you want to pay attention to those types of things in your codes. All right? So, for instance, 11000 and 11001 is infected skin. Okay? So if you weren't sure what eczematous meant, you wouldn't want to write infected skin. 11004 through 11006 is infected tissue, including muscle and fascia. So one is the skin and one is tissue with the muscle and fascia. Okay? And you'll notice that it says right at 11004, muscle and fascia. 11005 says with or without fascial closure. Code 11008 is an add-on code. And we only use it as an add-on code. This is for removal of abdominal wall prosthetic material or mesh for infection. I would definitely highlight removal of prosthetic material or mesh, so that jumps out at you when you're reviewing these codes. 11010 through 11012 is foreign material with open fracture or dislocation. Foreign material is what sticks out for me. And then 11042 through 11047 is subcutaneous muscle and bone. So your second category within the skin and subcutaneous is excision and debridement, which is what we just reviewed, those codes. You will notice, as I mentioned earlier, that there is a code that consists of a percentage, each additional percentage of the body surface. So as we move further and further into these codes, you want to make sure you're paying attention to those key words like we've talked about over the last 7 weeks. Okay? All right, excision of a lesion. excision of a lesion. It is not up to us to determine the size of the lesion. It should be in the doctor's notes, okay? So on page 529, down at the bottom, lesion, excision, and destruction. All right, the size of the lesion is taken from the physician's notes, not the pathology report, because your storage solution shrinks the tissue. So when they take a lesion, they will take healthy tissue around the lesion, which are called margins, and they are taken for comparison with the unhealthy tissue. So usually if you have a lesion that might just be, like this size, they might go at least through 1 to 2 inches around it. Because they want to compare the healthy tissue with the unhealthy tissue. And how many of you have had, brown spots removed? All right, you'll see that they've taken a nice size with the brown spot, and sometimes they have to dig a little because they want to make sure that they've gotten all of it to confirm whether or not it is cancerous, benign, or malignant. So depending on, how well the physician removes it, you could end up with a slight scar or a scar. Sometimes the scars just kind of close back up together like this. And sometimes where the brown spot was, you might find like a clear spot. And it's not brown. It almost looks like a blister. That's what it looks like sometimes. And it's not that the spot has grown, it's just the way that it healed afterwards. All right. So again, the physician will determine the size of the lesion. And you might want to make a note next to your codes to remind you that the physician determines the size. The lesion measurement, we just really went over that one. Usually 1 centimeter lesion with a 5 centimeter margin left and right. So it equals roughly 2 centimeters is what they take. But again, the physician will determine the size and let you know. So then based on these measurements, the lesion's actual charge before the excision and it gets sent to pathology is going to be different. Because again, once it gets to pathology, the air and solution will change the size of it. So it's important to know what those dimensions are for correct coding. Usually all excised tissue is pathologically examined, and then your destroyed lesions will have no pathology samples at all. This is where you use laser or chemical. So you're not going to have anything to send to pathology if you use laser or chemical. And usually your pathologist will examine all excised tissue. On page 531, we'll talk about closure, lesion closure. We have simple closure that's usually included in a removal. What is reported separately will be layered or intermediate. Your codes for layered through intermediate are 12031 through 12057. Okay. Usually for simple removal and closure, they'll use a local anesthesia. Just a local. However, your intermediate and complex closures are not included, and those might have to be coded separately. Pairing or cutting, down at the bottom of page 531. Pairing or cutting. This is removal by scraping or peeling. So this would be a removal of a corn or callus. Your codes would indicate the number 1, 2 through 4, 5 plus. These codes are used to report services that usually involve the removal of a benign skin lesion, such as a callus or a corn. You want to take note that code 11055, let's take a look at it, 11055 on page 73 in your CPT book. You'll notice under pairing and cutting you only have 3 codes. What do you want to pay attention to these 3 codes, Daniel? Page 73.
They're specific in the number.
Correct. There's only 3 codes, but they are specific to the number of lesions that applies to those codes. Okay? Your biopsy codes over on page 532. How is a biopsy distinguished from an excision? Fran?
With the biopsy, they're actually taking that tissue to see if it's cancerous or not. And the excision, they're just taking the thing out, like a cyst or something, as
Correct.
opposed to a hole or whatever.
Yep, correct. So what you want to pay attention to these codes is that not all lesions are removed. Okay? If they are removed, it is an excision, like Fran just said. You would not use the modifier 51. And as Daniel pointed out, each one of those codes are referencing a number of lesions. So pay attention to those. Skin tag removal on page 533. These are your benign lesions. They are usually removed with scissors, blades, chemicals, electrosurgery, that type of thing. We just lost Fran. You would not use modifier 51, and the codes again indicate the number. And for these codes, usually up to 15, and each additional 10 lesions or part thereof. So if you look at your skin tag removal codes 11200, let's take a look. Over on page 74, it's only 2 codes. So you have the primary 11200 and then the add-on code 11201. And skin tags are usually just flaps of skin that are benign, and they most often appear on your neck or the trunk, body.
That was weird. Sorry.
It is weird.
We just disappeared. Sorry about that.
You did.
How's it going?
I didn't go very far. We're just on skin tags.
Oh, okay. Thank you.
You're welcome. And you usually find skin tags in older people. It's very Not very often you find them in younger people, but they still appear. And again, they may be removed by scissors, blades, ligatures, chemicals, or electrosurgery. Shaving of lesions on page 534. They have a good example right at the bottom of page 534. And up at the top, they show you how scissors can remove it. Don't try this at home, especially if it's a really... Just don't try it, okay? So shaving of lesions, we talked about a little bit. Again, the lesion is removed, but it's superficial and it does not extend into the fat. Documentation should state shave removal if that's what is done. Again, it's based on the size and the location. So pay attention to the size and location, arm, hand, nose. Now, if you have multiple lesions on the arm, you can probably code all of those together when it comes to sizing. But if you have lesions on the arm, lesions on the leg, you can't group them together. You have to separate them. Okay? They usually don't require suture closing, and you would report the most extensive first without a modifier, then the least extensive from the different body area with a modifier 51. So like I just said, if we have some on the arm and some on the leg, the most extensive one would be coded first. So say we had 20 on the arm and 5 on the leg, you would code the arm first, then code the leg with a modifier 51. Okay? And if a biopsy is taken, you would not assign the 11300 category codes. You would actually use the 11100 for a shave biopsy. Okay? And usually to control the bleeding and stuff, they might use anesthesia or cauterization. Your benign and malignant lesions, these are codes 11400 through 11646. So quite a span of codes, all right? These codes are divided based on whether they are benign or malignant. The physician assesses the lesion as benign or malignant. The codes include local anesthesia and simple closure. You would report each excised lesion separately. And if the lesion is removed and the excision extends down to the fat, this is what is considered a full thickness removal, as you should be able to see. I don't have it. I thought you might have a picture in your book. All right. All right. So I'm going to give you a critical thinking question. Fran, I can't see you.
We're here. Hi.
Okay. All right. So there are 8 categories under the subheading skin, subcutaneous, and accessory structures. How would you know the correct category to code from? So let's say I give you an example. If we have a physician removing skin tags, what category are we going to code from?
Skin.
Skin tags. There is an actual skin tag category. Okay. All right, turn the page to 536. Nails. All right. Nails are on what? Our toes and our fingers. And the types of services that are performed on nails are trimming, debridement, removal, biopsy, and repair. So if you look at code 11719, on page 78 in your textbook, this covers the trimming of one or many fingernails or toenails that are not defective. So you'll see 11719 is trimming of a non-dystrophic nail, any number. So if you go to the podiatrist, they would use this code. Debridement covers the manual cleaning of up to 5 nails with the use of whatever tool is needed and cleaning materials. In avulsion, avulsion, is separation and removal of the nail plate with the root left to regrow. Sounds painful. But you would use code 11730 through 11732, and the number of units treated should be identified in the units column of the CMS 1500 form. That should be letter G. The modifier 51 should not be used because the codes indicate the number of nails. So 11730 would be for the first nail, 11732 would be for the second and subsequent. And as you can see over on page 537, at the bottom there, figure 18-14, you'll notice that there are modifiers. Modifiers for the hand and modifiers for the feet. And those tell the payer which digit and what side, right or left. And also, if you look in the front of your CPT book, remember you have some there also on the inside cover. All right, over on page 538, introduction. These are codes 11900 through 11983. The types of services that you will find here are your lesion injections, your tattooing, tissue expansion, contraceptive insertion and removal, hormone implantation services, subcutaneous hormone pellet implantation, and then insertion and removal of non-biodegradable drug delivery implants. Now, some lesions are actually injected. Who can tell me what might be injected for treatment? Darcy, what do you think?
I'm not really sure. I don't know.
Acne. Acne would be one. Sometimes what they do is they inject the type of infection or virus into the acne to make it go away. What they do is they test the acne to see what type it might be. And then if they have a treatment, they can usually inject it into the acne. Okay. All right. Repair and closure down at the bottom of page 539. As your types of wounds vary, the types of wound repair will also vary. So it's important to be familiar with the types of wounds. If you turn the page, you'll see the different types of wounds, and they require different complexities of wound repair. So you would definitely code based on the types of wound repair. And these would be codes 12001 through 13160. Now you don't have any pictures really in your CPT book, but on page 540 in your textbook, you'll see the different examples that they give you for laceration, puncture. How many have stepped on a nail or accidentally, walked up past something that was sticking out and got jabbed with it? An abrasion, some kind of a burn, an avulsion, where the nail comes off, where the skin comes off. That just looks awful. And then an incision, where you accidentally cut yourself with a knife, or you get a fish hook stuck in your finger or your head. What else? Fall off your bike and scrape a couple layers of skin off. Am I missing any? Oh, how about when you stub your toe and you rip the nail off? That would be good, yeah. All right, so repair factors. It's going to be based on the length and the complexity. So is it simple, intermediate, and complex? And then what is the site? So your wound repairs are length, complexity, and site. So as we were talking about simple, the simple wound repair is superficial. It's the epidermis, the dermis, and the subcutaneous tissue. The intermediate repair, over on page 541 in your textbook, the intermediate repair is going to be layered closure of one or more of the layers of subcutaneous and superficial fascia with skin closure. Your complex is greater than layered. This is where the scar revision or complicated debridement or extensive undermining, stents, extensive retention sutures. Included in your wound repair codes, over on page 542, is simple ligation of vessels in the open wound. Then you have simple exploration of the nerves, the blood vessels, and the exposed tendons. With your simple repair, there's normal debridement, and you might have additional codes for debridement if there's gross contamination or appreciable devitalized contaminated tissue that must be removed to expose healthy tissue, such as someone who's had a really bad burn. So again, your wound repair will include the main components of ligation, exploration, and debridement. So, when you get a cut, you always kind of open it up more, you see how bad it is, so you're exploring, and then you clean it out. So grouping of wound...
Oh, sorry, Doreen. Just a question.
Sure.
I know you said simple repair includes local anesthesia. Do you have to put separate for intermediate, complex? You list that separately or no?
Only if it's indicated.
Okay.
Because sometimes the codes will say report separately, and that's when you report it separately.
Okay, cool. Thank you.
Yep. So how do we group the wound repair? We touched upon that just a little bit earlier when I said about your arm and your leg. So you add them together by lengths. So your complexity, simple, intermediate, or complex. The location, is it face, ears, eyelids, nose, and lips? 1 inch will equal 2.54 centimeters. So if you can remember that 2.54 centimeters equals 1 inch, you'll be able to easily calculate all of these exercises that you need to add up for your codes. But let's say we have a really complex wound in the scalp. You've got to shave some hair out of the way to really clean that gash, okay? And then you've got some, let's say, slight wounds on the shoulder. So someone, let's just say they were riding a bike, they fell off, and they skunned their shoulder and arm and everything. But the gash on the head is the complex one. So you would code the gash on the head first because that's complex, that's major. But the gash and stuff down the arm, again, it's going to be length, but also the location, and is it simple, intermediate, or complex? That one on the arm is really just simple. Just needed some cleaning up and maybe some butterfly sutures or what are those, steri strips. So pay attention in your exercises to those types of things, okay? You do not want to group wound repairs that have different complexities, and I think I just made that clear. If it's simple and complex, they're two totally separate. But if on the arm, on the forearm and the upper arm, we have different types of gashes, again, you want to know how long they are, but you can group it as one because it's all on the arm. Okay. Tissue transfers, grafts, and flaps on page 542, sorry. With your tissue transfers, we have an adjacent tissue transfer or rearrangement. These would be your Z-plasties, your W-plasties, and your rotation flaps. Your adjacent tissue transfers include excision of the lesion. What would be the purpose of a transfer or a grafting procedure? What do you think, Fran?
Probably if the skin they were taking away was not able to be repaired or sutured down, they'd want to put fresh skin down.
Yep. To correct a defect, right.
Yep.
Correct. So to correctly code grafts, you should know the type of graft, the donor, the recipient site, and the repair required for the donor type. In all cases, the size of the site coded must also be known. And you'll see on page 543 and 544, they give you some examples of the different types of grafts that they do. Your split thickness and your full thickness grafts. The split thickness graft is the epidermis and some dermis. The full thickness graft is the epidermis and all of the dermis. A free skin graft. Who can tell me what a free skin graft is? right, a free skin graft is a graft that is completely detached from the donor site, and then it's coded based on the recipient site and the size of the defect measured in square centimeters and the type of repair. We've talked about the graft types already, the split thickness and the full thickness. Some other graft types are skin substitute grafts, where artificial skin is used. What is artificial skin, Daniel?
Well, artificial skin is just that. It's skin that's been made by humans.
Yep.
Some sort of elastic, if I remember.
Right. I think they call it a bilaminate skin graft because it's man-made. Okay? Your allograft or your autografts are donor grafts. This is where tissue is cultured. Epidermal autografts are grown using donor cells. And then your xenografts are non-human donors, like a pig. All right. Tissue transfers, grafts, and flaps. You'll see on page 546, there's some skin replacement surgery as well as flaps where some skin is left attached to blood supply. Skin replacement surgery. Your codes are to report the site preparation and the repair using skin or skin substitutes. A defect site repair is reported with 15002 through 15005, and these are based on the size. A defect site is called a recipient. Your free skin grafts, again, are split thickness or full thickness. They are completely freed from the donor site and then placed onto the recipient site. Your skin substitute grafts, they're going to be reported based on the wound in the surface area. Now, you'll notice too that a lot of these codes have their centimeters, up to 100 square centimeters, or each additional 25 square centimeters. Pay attention to the square centimeters. Flaps that we mentioned a little bit earlier, these are left attached to a blood supply, which keeps the flap viable in order for them to prepare the donor site. Flaps may also be done in stages. You can see on page 546 that they created a flap in order to repair the woman's breasts. Formation and transfer of flaps. Again, the formation is based on the location. So is it trunk, scalp, or nose? I was watching a show probably in the last month or so, and one of those medical shows where they were actually going to attach a man's hand or finger to his abdomen until they could actually put it back on or reattach it for something.
I've heard of those. It's to keep the finger alive during the time of
Yes.
the procedure.
Yes. I thought, oh, that's a perfect example.
Not very common, but they do it from time
Yep.
to time.
So I thought that was interesting that they actually used it. Let's see. Flaps can also be muscle, myocutaneous, or fasciocutaneous flaps. When you have repairs, they're going to be made with muscle and skin, and fascia and skin. The flaps usually rotated from the donor site to the recipient site. They include closure of the donor site, and then your codes are going to be divided on location. So is it a trunk or an extremity? And then you're going to see it as also see an add-on code, which reports the soft tissue reinforcement with biological implants. Again, make sure you query the documentation, ask the provider if you do not understand anything. Tube flaps. You see that on page 546, tube flaps. This is where an inset of a tube flap following separation from abdominal blood supply. This process is waltzing or walking tube. You'll see that the tube flap from the abdomen to the chest. Your pressure ulcers. Let's talk about pressure ulcers. Page 548. You will find that there are excision and various closures. Primary would be skin flap and muscle. And you're going to see many codes with ostectomy, which is bone removal. What are pressure ulcers? Darcy?
Is it an ulcer that forms on the bone?
No, not necessarily. It's someone who's been bedridden or sitting and, bedridden for too long. Or they sit all the time.
Bed sores.
Pretty much bed sores. You've heard them called as bed sores. But yes, they can get down to the bone. And that's where it can be they can become very painful. As you can see on page 549, the different stages of what they show as bed sores. So, stage 1, not too bad. Might be able to take care of it. But as we get into stage 2, stage 3, and stage 4, that's pretty big, bad bed sore. But they're usually located at the end of the spine, between the hips, the lower hip, and the femur. Burns, over on page 550. You're going to use codes for small, medium, and large. You would most calculate the percentage of the body burn using the rule of 9s. You'll notice that for children, it is different. What are the rules of 9? The rules of 9 is a method to calculate the percentage of the body area that is burned in an adult. You'll notice that each section on the body accounts for a different percentage, but all adding up to 9. When you document the burns, report both the percentage of the body's surface area that's affected by the burn and the depth of the burn, because these two characteristics, they go together to reveal the severity of the burn, and it's recommended for treatment. So again, small is less than 5%, medium is 5 to 10%, and large is greater than 10%. For children, they use the Lund-Browder. It's called the Lund-Browder, and you'll see the percentages, how they differ for children. They're usually relative proportions of the body area. Often with burns, you'll find that they require multiple debridement and redressing. These are going to be based on initial treatment of the first degree burn and size. So you always want to report the percent of the burn and the depth. When the burns are treated on a daily basis, many payers allow each day of treatment to be billed for. All right, page 552. Let's talk about destruction. I lost Fran again. All right, destruction in this chapter, in this section, is all about ablation, which is destruction of tissue. This is where we use laser, electrosurgery, cryosurgery, chemosurgery. It's determined to be either benign or malignant or premalignant. And it's based on location and size. And this happens to be another subheading in the integumentary subsection. You'll also notice on the bottom of page 552, Mohs microscope, Mohs micrographic surgery. This is where the surgeon acts as pathologist and surgeon. It removes one layer of lesion at a time until no malignant cells remain. And it's based on location, stages, and number of specimens stated in the report. Over on 554, breast procedures. These are divided based on procedure, such as incision, excision, introduction, mastectomy procedure, and repair or reconstruction. You'll notice that the mastectomies are based on the extent of the procedure, such as simple, radical, modified radical. Your bilateral procedures, you're going to use a modifier 50. With an implant insertion, those will be billed separately. Note that if a lesion is removed from the skin of breast, use one of the 11400 codes. If the lesion is removed from the actual breast tissue, use 19120. Your introduction codes for the breast, you have markers or localization devices that are inserted into the lesion to mark the lesion. As you can see in your textbook on page 554 in the bottom left-hand corner, you see that there is a guided wire marker, and these are reported separately. So report is based on guidance that is used. Any questions? Daniel, any questions? Pretty straightforward. Why don't we take a quick break and come back? Let's say 5 minutes, okay? Everyone back? All right, let's move on to chapter 19, page 559 in the textbook. Is there any need to go over the answers on the end of the chapter, or going online okay with that?
Going online's okay with me.
All right, so just go online, and if you have any questions, don't hesitate to email me, okay? All right. Chapter 19, musculoskeletal. So 559 is the chapter topics. 560 starts musculoskeletal. In your CPT book, let's turn to page. Now, what I like about the CPT book, on page 99, if you look, 99, 100, 101, 102, and 103 actually give you some really nice examples, some really good illustrations for the body, the skeleton, the skull. It points out the muscles for you. It also shows you the vertebrae, the lumbar, the thoracic. It shows you the lateral view. And then if you look over on 102 and 103, it shows you the hands, the bones, the muscles, the same thing with the feet. So some really good illustrations here. And if you need to make notes, you have a blank page 98 and some white space within these preceding pages to make your notes, so that when you are taking the test, you know where to come and find the information. I need to pull out a tab. All right, remember, as I talked about in previous chapters, that you have notes in your CPT book. You have notes in your ICD-9 book. What are you going to do with those notes? You're going to read before, during, and after. Okay? So, musculoskeletal system, page 560. This section is divided by anatomic site. All right, and actually it's a subsection. Musculoskeletal is a subsection, and it is divided by anatomic site. So forearm, wrist, and then the type of service that's being performed. All right. It is used extensively by orthopedic surgeons. And you will find that many codes here also are commonly used by a variety of physicians. And as I just mentioned, extensive notes. So your subsections reflect the anatomical sites, and each anatomical site has a subheading that reflects the procedure performed. You're going to see a lot of musculoskeletal codes that are used for splinting, casting, fracture repair procedures, and these are also used by your primary care and family practice physicians. Some of the most common things you will see in here are fracture and dislocation treatments on page 561, general subheading, arthroscopic procedure, cast, and strapping. So some of the other things you might find under here are miscellaneous procedures that might not be specific to an anatomic site. An example would be incisions of soft tissue abscess or wound exploration or biopsies of the muscle and the bone tissue. When we're coding fractures, some of the questions that you want to ask when you're coding fractures are, what's the site of the fracture or the dislocation? What type of treatment is it? Open or close? So I'm on page 562 in your textbook. What manipulation is performed and is it documented? Was traction used? If so, what type? Was percutaneous fixation used? Was internal fixation used? Make sure that it is not included in the code descriptor. Was an external fixation system applied? Did documentation support skin closure? And what type of anesthesia was used? For fracture treatment for an open fracture, usually surgically opened. Why? Because they want to view it or remotely open to place a nail across a fracture. Open reduction with an internal fixation. Also, the acronym for that is ORIF. Closed traction. Closed traction is where the fracture site is not exposed by surgical incision. Percutaneous is neither open nor closed. It's where fixation devices, such as pins, are placed across the fracture site under imaging. Treatment terms are not to be confused with the type of fracture. An open fracture means what, Darcy? What's an open fracture mean?
The fracture has broken through the bone cortex and the bone has been exposed to air
Right.
elements.
So basically it's penetrated the skin. Gross, right? What's a closed fracture, Daniel?
Closed fracture can be almost anything, but as long as it's not exposed to air.
Right. So no breaking of the skin. Perfect. All right, so the type of treatment is going to depend on the type and severity of the fracture. If we see a complicated in a code descriptor, this might indicate excessive hemorrhage or infection or prolonged physician work or difficulty in reaching the site or depth of the site. All right, so when you hear complicated, it could mean a multitude of things, so just be aware of that. What type of fracture treatment would most likely be used for a green stick fracture? What do you think, Daniel?
Probably a cast.
Open or closed?
Oh, open or closed? That's closed.
Closed, right. All right. For, let's see, for traction. Let's see, traction. Over on page 564, traction. Application of force to align a bone. All right, you can see figure 19-4 is traction to pull the force to hold the bone in alignment. And 19-6, skin traction, utilizes strapping, wraps, or tape. So you have different types of traction. Skeletal traction is figure 19-5. Use of force. Distracting or traction force applied to internal device such as wire, pin, screw, or clamp. This is inserted into a bone. So there are two types of traction, skeletal and skin. The skeletal traction are the internal devices, and the protruding ends attached to traction devices that use weights and pulleys to hold the bone in place. Your skeletal traction, does it require an open procedure? No, because the internal devices are inserted through the skin. Skin traction is application of force by means of adhesion to the skin, and then they pull. Manipulation. Manipulation is use of force to return a fractured bone to a normal alignment. Fracture repair codes are often divided based on whether manipulation was or was not used. This is also known as reduction. So in your exercises, if you see reduction, you should also think of manipulation. Okay? Manipulation means a fracture has been reduced. Fractures are described by a physician in terms of the direction of the fracture line. So is it horizontal? Is it vertical, oblique, spiral? And the direction and the degree of the angulation, the most distal fragment. So if we say distal fragment, that means pointing, yes, furthest away from us. When the fracture results in more than two fragments, it is comminuted. Comminuted. So a fracture results in more than two fragments, comminuted. And you notice on page 561 in your textbook, it has a really good example of comminuted fracture. Two fragments, or more than two fragments. All right, dislocation on page 565. Bone is displaced from normal joint position. Treatment, return the bone to a normal joint position. So you see figure 19-7, that is a vertebral dislocation. The disc has slid forward. And if I had remembered, I would have brought a skeleton with me.
So that's basically when the disc slips.
Mm-hmm. A disc has slipped forward. A subglenoid dislocation, they show you that on the looks like the hip. So what's the difference between a fracture and a dislocation? A fracture is where the bone is broken. A dislocation is where the bone has just been displaced from a normal position. All right, another subheading in your CPT book is the general subheading. And under that, on page 566, it begins with incision. Incision, and then depth. The depth here is the difference between integumentary and musculoskeletal incision codes. Musculoskeletal is used when the underlying bone or muscle is involved. So when we're talking about the depth in musculoskeletal, it is going to be in reference to the underlying bone or muscle. Wound exploration on page 567. This is where the traumatic penetrating wounds happen. These are divided on wound location, so on body site, divided on body site, and they include enlargement, debridement, foreign body or body's removal, ligation, and repair of tissue and muscle. So they may have to do some wound exploration. I hope that they anesthetize the area so you don't feel anything or they just knock you out. Another general subheading under wound exploration, some of the things that you're going to see is that they will describe surgical exploration to an already open wound. The codes you will see might also show, say, separate procedure. If they can be coded and reported in the following circumstances: if only the procedure is performed, and if totally unrelated to another procedure performed at the same time. So pay attention to the code descriptors. Biopsies on page 568. These are located in the excision subheading. Biopsies can be of the bone or the muscle. These are going to be divided by the type of biopsy, the depth, and some actually by method. Your codes for biopsies of muscles and bones are going to be listed under the excision general subheading. Now, a biopsy can be performed percutaneous needle or excision, and these are usually coded separately, and it should tell you that. If the lesion excised and biopsied, you're only going to bill the excision. If a biopsy is taken on one day and based on the results an excision was performed, you would use a modifier 58. That would be appropriate on the excision code. Your modifier 58 basically tells you that you've decided to go back and remove it. Staged or related procedure. Your introduction and removal are going to also be within the general subheading. You're going to find that these are codes for injections, aspirations, insertions, applications, removals, and adjustments. The other thing that you will find underneath general introduction or removal will be therapeutic sinus tract injection procedure. Please keep this in mind, okay? Therapeutic sinus tract injection procedure. This is not nasal sinus, okay? It is the sinus tract that is in your buttocks, okay? I highly suggest you Google it so you can see what I'm talking about. They won't show you a gross picture, but so you understand what they're talking about when they're saying sinus tract in the musculoskeletal region, okay? It's actually quite interesting. So keep in mind, when you're doing your exercises and it comes across sinus tract, it has nothing to do with your nose, okay? It is an abscess or a cyst with a passage to skin, and usually antibiotic is injected with use of radiographic guidance. So the term sinus actually describes a fistula that leads away from a pus-filled cavity as well as the air-filled cavities in the bones of the skull. A sinus tract injection procedure code is used for the treatment of an abscess or a cyst through injection of an antibiotic or other substance into that infected sinus via the sinus tract. And again, it's done with radiographic guidance, and really Google it so you know what I'm talking about. Removal of foreign bodies. These are lodged in muscle or tendon sheath. Integumentary removal codes would be for removal of skin. Injections. Injections into the tendon sheath, ligament, or ganglion cyst, or trigger joint. Those also fall under introduction and removal. Your injection codes are on the bottom paragraph, page 568. Arthrocentesis is an injection and or aspiration of a joint. Over on page 569, arthrocentesis, again, aspiration of a joint. This is where both an aspiration and an injection are reported with one code. You've heard me talk about combination codes before. This would be one of those codes. Local anesthesia is integral to these codes, and they should not be reported. So Fran was asking me earlier about anesthesia and something else. Again, pay attention to the notes before, during, and after. Pay attention to your guidelines. They will tell you, just like it just did here, that it is not done separately. So, HCPCS modifiers are also used to report specific digits. As I showed you earlier in the chapter, you have hand and feet, and it shows right and left. External fixation is the application of a device that holds the bone in place. On page 570, external fixation. These codes will include the removal of the fixator. If it is necessary to adjust or revise the fixator, you would use code 20693. Code 20694 actually describes removal under anesthesia and includes imaging. With your external fixation, you will see that there is a uniplane. A uniplane are pins and wires in one plane, so a flat, smooth surface. A multiplane requires complex adjustments and correction in alignment. Bedside adjustments are not separately billable. Code fracture treatment and external fixation, unless treatment and fixation are both included in code description. Grafts or implants on page 571. These are used to report harvesting through separate incisions of the bone, the cartilage, the fascia lata, and tissue. These involve morselized or structural bone taken from a donor or from the patient. The morselized small pieces of bone. Structural is a segment of bone machined into the space. You would report only one bone graft per operative procedure. Your fascia lata grafts are usually from the mid-upper thigh, where the fascia is the thickest. Some codes actually include obtaining the grafting material. Then they are not coded separately. Your composite grafts, they involve combinations of autogenous material and allograft or alloplast. What is fascia? Daniel, what is fascia?
It's a connective tissue.
Yep, it's a fibrous connective tissue. Good. All right. Other procedures on page 572, such as monitoring muscle fluid pressure. This would be the interstitial. Pressure increases due to increased accumulation of fluids, causing blood supply to be compromised. Bone grafts are identified by site that they are taken from. So where are they taken from? That would be the donor site. Free osteocutaneous flaps are for bone grafts taken along with the skin and tissue overlying the bone. So a free osteocutaneous flap is where we take along with the skin and tissue overlying the bone. Electrical or ultrasound stimulation is another procedure that is used to promote healing. It's using low voltage electricity or ultrasound being applied to the skin. These are used often in treatment of fractures or trauma. Electric stimulation can help repair fractures and help them to heal. The vertebral column, you notice on the bottom of page 573, they show you the vertebrae from T8 down to L2, but your vertebral column is actually divided by repair locations, so it starts all the way at the cervical and goes all the way down to the tailbone. The cervical starts here at the base of your skull. It's actually the atlas and the occipital, and then you have 7 vertebrae in your neck, and you have 12 vertebrae in your thoracic spine, and then 5 in your lumbar plus your sacrum and your coccyx. They give you, as I showed you, they have a diagram in your book, and I believe they had one here in your textbook also. Incision for musculoskeletal talks about open incision and drainage of deep abscess of the spine. These can also be divided by location. Your cervical, thoracic, or cervicothoracic, and then you have lumbar, sacral, or lumbosacral. Arthrodesis, over on the page 573. Arthrodesis is fixation of a joint. It's basically where a joint has been fused together. It is usually fixated with pins, wires, rods to immobilize that joint. Often this is performed with other procedures such as a fracture repair. Use modifier 51 on the arthrodesis code, unless the service is reported as an add-on code. When you code the arthrodesis, you're going to code by approach, by site, and number of interspaces or segments. Spinal instrumentation, middle of page 573. You want to look at the types of spinal instrumentation. Segmental would be devices at each end of the repair area, plus at least one other attachment. Your non-segmental is devices at each end only. You're going to find extensive notes, as I've mentioned all along. There are notes throughout. And you would report, in addition to the definitive procedure, without the modifier 51. Some subsequent subheadings after your first subheading, general, it is divided by anatomic location. Your anatomic subheadings are then divided based on the type of procedure. So some of the subheadings that you will find on page 574 in your textbook, some of the subheadings might read incision, excision, manipulation, head prosthesis, introduction or removal, repair, revision, reconstruction, fracture, dislocation, and other procedures. Let's talk about cast and strapping. On page 575, cast and strapping. They have some figures there for you to look at for types of strapping and casting that they do. This is a replacement procedure or an initial placement. And what it does is it stabilizes without additional restorative treatment. The initial fracture treatment includes placement and removal of the cast. So keep that in mind when you're coding. The subsequent cast applications are coded separately. The initial cast is not coded when it is part of a surgical procedure. The removal is bundled into the surgical procedure, and the supplies are reported separately. So you have bundling going on there. You can pay attention to that. Endoscopy and arthroscopy. This is surgical arthroscopy. Always includes diagnostic arthroscopy. Your codes are divided by joint, and they are subdivided on procedure. Diagnostic arthroscopy codes are only reported for cases where no surgical scope is performed. The exception is diagnostic scope that determines need to do open surgery on the same day. You would use your modifier 51 here for the diagnostic scope. Why is arthroscopy often the treatment of choice for orthopedic surgical procedures, Darcy?
Can you repeat the question? I'm sorry.
Why is arthroscopy often the treatment of choice for orthopedic surgical procedures?
I'm not really sure.
Because it's less invasive. The incisions are smaller, so there's a lower risk of infection and your recovery time is shorter. All right. Pay attention to the parenthetical information in this section for endoscopy and arthroscopy. The codes are going to be indicating which one is to use for procedure, whether it's open or closed. Most of your arthroscopies will include local infiltration of medication, suture removal by operating surgeon, surgical approach, wound culture, intraoperative photos and video imaging, isolation of the neurovascular structures, stimulation of the nerves for identification, placement of drains and suction devices, and wound closure. And I think we lost Gardner altogether.
There was an issue with Gardner on Tuesday, too.
Really?
Yeah.
All right, that's that's it for 19. That's musculoskeletal. Any questions? Now, did you guys do the homework for this too, or just the reading?
I did some of the questions for some of the CPT and ICD-10 stuff.
And how did you feel about those? Good?
Good. Except for number 16, I wasn't exactly sure on that one, but I figured it out.
Okay. How about you, Darcy?
I did okay.
How do you feel about the chapter?
I feel pretty good about it.
Okay. So out of the last 19 chapters, what would you say was your favorite? You have a favorite yet?
I kind of liked chapter 20, honestly. I like using this book a lot more. The stuff in it is a lot easier to look up now that I know how to use it. It's easier than this.
Yeah.
Yes.
Yeah.
The information is more readily available.
Good. All right. So what do you say we go on to respiratory and cardiovascular and just do some of the workbook exercises? I'm focusing specifically on the reports because those seem to get everyone. Really? So I won't touch the textbook. We'll just move right on into the workbook for chapter 20 and 21. So let me give you the assignment for next week. The assignment for next week is week 9, chapter 20 and 21. Again, up to this point, you should have had all of your Evolve exams completed and in chapter exercises as well as homework. And for next week, read 20 and 21 and do as much of the exercises as you can. Usually the even numbers. But let's go ahead into the workbook and pick on report 60. Number 60 is report 21. And page 222 is report 21. So atelectasis of the right lower lobe, suspecting either a mucus plug or obstructing cancer. The postoperative is mildly inflamed airways with some thick secretions. No definite mucus plug was seen, and certainly no cancer was noted. The procedure that was performed was a bronchoalveolar lavage, bronchial brushings, and bronchial washings. Oh, everyone loves this one. I say that because... All right, so what we're going to look at here is... All right, so we talked about pre- and post-operative diagnoses and how when you have a pre and a post, you usually want to code the post-operative diagnosis. But then the procedure that was performed was the bronchoalveolar lavage, bronchial brushings, and bronchial washings. Now, you're going to have 2 CPT codes here. So where would we start? What are they working on? The lungs? So I'm going to go to lungs, and I'm going to look up a lavage. Now, I can even go to lavage, lung, page 895 in my CPT book, in the index. Under lavage, under lung, it gives me bronchial, and it gives me total. So the first code I'm going to look up is the 31624. And if you haven't tabbed your books, I suggest you tab them because it makes it so much easier to find the code. So code 31624 is on page 179 in your CPT tabular. And 31624 says with bronchial alveolar lavage. Well, we know that that is done with moderate sedation. And we know that this is a subcategory to the 31622. The 31622 is bronchoscopy, rigid or flexible, including fluoroscopic guidance when performed, diagnostic with cell washing when performed, separate procedure. So they did a bronchial brushing and bronchial washing. If we go down to 31623, it says with brushing or protected brushings. 31624 is with bronchial alveolar lavage. And 31625 is with bronchial or endobronchial biopsy, single or multiple sites. Well, the first thing they did was the lavage. The second thing they did was the brushing. So what code are we going to choose first? What do you think, Darcy?
The 31624.
Yep. And Daniel, what do you think is going to be next?
I really don't know.
It's going to be the 31623 modifier 51. So, why did we choose these codes? We know 31622 is the major category. So, we know that they did a bronchoscopy, right? By reading the report, we know they did a bronchoscopy. So, subcategory with bronchial alveolar lavage. That's the first thing that they did. Then, with the brushing or protected brushings is 31623. So, we did the 31624 first. We don't need to code the 31622 because the 31624 is part of that. When we pick 31624, we're saying they did the bronchoscopy and they did it with the lavage and then they did it with the brushing. Does that make sense? So we're only going to put the lavage first because that's what they said first. That was the most intensive. And then the brushing with a modifier 51 because it was an additional procedure. All right, does that make sense? So now let's look for our diagnosis. All right, our diagnosis. Where are we going to start with our diagnosis?
The chronic adenotonsillitis.
Where'd you get that?
Under the post-operative diagnosis.
Are you on operative report number 21?
No.
Okay.
Wait, no, I'm not. Sorry.
Okay. All right, so in order for us to get our diagnosis, we actually have to go to the pathology report that is later indicated, which is C report 66. So when we go to report 66 on page 247, go to page 247, and the pathology report or the lab report tells us atelectasis of the lung. Diagnosis is atypical cells cannot rule out malignancy. So we just did a bronchoscopy of the lungs. So they're saying they cannot rule out malignancy. So if we have something in the lungs, atelectasis of the lung, what's that considered sometimes, Daniel? Or what is that considered to be?
I don't know.
A neoplasm. So we would start looking up neoplasm. So we would go to our neoplasm index. In our ICD-10 book, and go to lung. All right, and what part? It was the lower lobe. And we don't know the behavior. So on page 1349 in your neoplasm index, lower lobe, uncertain behavior, we have D38.1. D38.1. So let's go into our tabular. D38.1. All right, D38.1, page 202 in your tabular. All right, D38, neoplasm of uncertain behavior of middle ear and respiratory and intrathoracic organs. Excludes 1, neoplasm of uncertain behavior of the heart. D38.0 is neoplasm of uncertain behavior of larynx. And it goes on to list 2 others. Then it tells you excludes 1. Over on the right page, 203, D38.1, neoplasm of uncertain behavior of trachea, bronchus, and lung. Now we can continue on and it will tell us pleura, mediastinum, but what are we looking for?
Trachea, bronchus, and lung.
Right. So it would be D38.1 is our diagnosis code for this exercise. All right. All right, how about number 62, report 24? Report 24, page 224. All right, the procedure performed was a fiber optic bronchoscopy, bronchial biopsy, bronchial washings, bronchial brushings. So what was the procedure performed? A bronchoscopy. And what did they do? They did biopsy and brushings. What do you have, Darcy?
31638.
No, you went too far. You said 31638, right?
Yes, it says in there that it went through a introduced through the endotracheal tube, which was previously put in, wasn't it? That's what it said, I thought.
Right. But you don't want to, you're not looking for what's in the description because they're telling you in the procedure performed exactly what was done.
Okay.
So you went a little bit too far. You really
Okay.
only needed to stay on page 179 and decide among those four codes again. Because they did a bronchoscopy, and they did a biopsy, and they did a brushing. So in this instance, you would want 31625 as your first code with the bronchial or endobronchial biopsy, single or multiple sites. And then back to the 31623 with the modifier 51. So in this case, when they said that the bronchoscope tube was introduced through the endotracheal tube, basically what that tells me is it was a rigid or flexible. That's all that it says to me. So you just went a little bit too far into the bronchoscopy. Daniel, are you looking up the diagnosis?
The thing for the ICD-10, I already got the 31623 thing.
Mm-hmm.
So now I'm just looking at the abnormal diagnostic imaging for lung. R91.8.
So you're not looking up the pneumonia?
Oh yeah, post-procedure.
So the diagnosis for this would be pneumonia. So that one's real simple. That one would be J18.9.
Does it say in the report pneumonia or just abnormal chest x-rays considered pneumonia?
It says post-procedure diagnosis, inflammation in all lobes, pneumonia.
Okay.
With pleural plaquing consistent with possible candidiasis, but what you're really concerned with is the fact that it's pneumonia. And then when you go to look up the pneumonia code, you're going to choose the first one in the alphabetic index. Let's go to it. Let's take and go to it so you can see. Pneumonia. Page 1394 in your alphabetic index in your ICD-10 book. About middle of the way down on that left-hand column, it says pneumonia. And then in parenthetical notes, it says acute double migratory purulent septic unresolved. And it says J18.9. I would not go any further than that because it's not clearly giving you an infection. Okay? It's just telling you possible candidiasis. It didn't come right out and say what type. So remember your parenthetical notes there? Those are usually what? Modifiers. So you would just take that information, go into J1 8.9 and confirm, is that the code I need? So J1 8.9, page 398 in your ICD-10 book, J18 pneumonia, unspecified organism. Because it said possible, it didn't confirm it. So if you go all the way over to J1 8.9, pneumonia, unspecified organism. Okay? All right. Let's go to Chapter 1, cardiovascular. We're going to go to page 138. We're going to do report number 63, which is report 26. Page 138 in your workbook. Report 26. Okay, report 26 is on page 225. Cardiac catheterization report. It's a long one. So the procedure performed is a left-sided heart catheterization, selective coronary angiography, and left ventriculography. Ventriculography.
We're doing 26 or 25?
Oh, sorry. Page 225. It's number 26. So it's a coronary artery bypass surgery. Also, the acronym for that is CABG. You hear people call it cabbage. So single vessel coronary artery bypass grafting out Lima to Lad off pump. That is the procedure that was performed. So really, a coronary artery bypass graft with an arterial bypass, that's what you want to look up. Coronary artery bypass graft. Okay, so if you turn to page 816 in your alphabetic index and your CPT book, in the middle column, about midway down, coronary bypass graft, it says see coronary artery bypass graft. Go down further, coronary artery. Coronary artery bypass graft over on the third column. And what type is it? The report says again, the report says that it is arterial bypass. Sorry. What'd you get for CPT code, Daniel?
33533.
What'd you get, Darcy?
33533.
Good job. Perfect. Excellent work.
This one.
Yeah, the diagnosis part is a little trickier. Arteriosclerosis of the coronary artery. Yep.
Does the depressed LV function make it a specified type?
Where are you seeing that?
Arteriosclerotic coronary artery. I guess I could just go to I-25.10.
Yep.
Yeah.
Yeah, because
Yeah.
I would start there.
I was just looking to see if there's anything that
Yep.
matched that.
Nope, that
first.
was good. All right. How are you doing with the diagnosis, Darcy?
Okay.
Where are you at?
I'm at I-25.10.
Yep.
I think that's it.
That's it.
Exactly what.
Right. All right. So, does that help a little bit?
Very much.
Does that help?
Yeah.
All right. So you guys have two pretty good chapters coming up, 20 and 21. I will tell you right now that most students find 21 to be a bear. Okay? So I'm going to tell you to go into it with an open mind. Okay? Do not go from 20 to 21. Take a break between the two. Do them all together all at once. You will go crazy. Any questions? What is your takeaway from tonight, Darcy?
I don't know.
Daniel.
Tab arteriosclerosis and those two together. Just finding the one with
Yes, arthero and arterial. Definitely two separate things.
It's frustrating that they can sometimes be the same thing, but they're not.
Right, and when you're tired and you're looking at them, they can become frustrating. So I will end on that note. Thank you very much for your time and attention tonight. I appreciate it. And we'll see you back here next week.
Okay, thank you.
Have a great week. Thank you.
You too.